Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and chapter immunization representative at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. Today is May 25th, 2021. Globally, the total number of COVID-19 cases stands at 167,466,000 and a bit, with nearly 3.5 million deaths related to SARS coronavirus 2 infection since the start of the pandemic. In the United States, our total case numbers are 33,158,834, so getting up there again, but a much slower increase, thank heavens. In fact, the daily average number is below 30,000 for the whole country for the last several days counting, which is really good news. Unfortunately, our death rate is almost 591,000 since the start of the pandemic. In kids, specifically, looking at the AAP report dated May 20th, the total caseload is 3.94 million cases, which is just over 14% of the total caseload of all patients. That comes out to 5,239 cases per 100,000 patients of pediatric age range. Here in Arizona specifically, our caseload for kids, this is birth through age 19, is 142,966, which is 16.3% of our total caseload for the state. That comes out to 7,776 cases per 100,000 pediatric age range. So the numbers are not, thankfully, significantly worse than they were before. We continue to climb, of course, but currently, we are back to the low numbers that we were at prior to last surge for last winter. This week's questions, most of them have to do with vaccination, thankfully, and yay, it's great to have vaccine emergency use authorization for the Pfizer vaccine for age 12 and up. That has been officially endorsed by the FDA and also by the AzAAP. It sounds like Maternal has just now released its data for vaccine safety and efficacy for 12 years and up to the FDA for a similar bid for emergency use authorization. So we can anticipate evaluation of those numbers and hopefully an EUA authorization sometime in the next several weeks. Let's start with the first question that was sent to me. Speaking of EUAs, I see that with the emergency use authorization for Pfizer's COVID vaccine, the AAP and also the CDC is supporting co-administration of that COVID-19 vaccine and routine immunizations in our adolescent patient population. Have any studies been done to confirm that there are no adverse effects on the efficacy? If not, how do we know that this is prudent or not prudent? Very appropriately, the questioner is combining understanding of science and immunology with the fact that we don't have definite proof. So this is a very important question, and it is currently being assessed by the Advisory Committee or Council on Immunization Practices, the ACIP. But both the AAP and the CDC have stated that based on other data from other co-administration of immunizations, that the immunology related to vaccine response for the messenger RNA vaccines is or should be completely safe and efficacious when co-administered with other vaccines. And at least on the surface of things, and from what we know with vaccine immunobiology, that's true. That is true. The major concerns, as we all know, are when administering live virus or attenuated virus vaccines, such as MMR and varicella, that they need to either be administered together or at least 2 weeks apart. And that is based on immunology or immunobiology, which suggests a down regulation of response should there be interference between the adaptive immunity response to a single vaccine. So at least based on prior experience with messenger RNA exposure and protein antigen exposure due to messenger RNA vaccine, things should be safe. But the very blunt, transparent answer is that the studies have not been done yet looking at outcomes of seroprotective levels of all vaccines when co-administered with a COVID-19 vaccine. We certainly have come to expect when we look at a combination vaccine product such as the upcoming hexavalent vaccines, we've come to expect that data will be provided to show that there is non-inferiority in the immune response to all the vaccine responses to the various antigens when co-administered. And there just hasn't been time yet. However, I think it's important to also realize and point out in our conversations with our families and patients that the risk of under-vaccinating, as we certainly are experiencing right now, is extreme, to put it quite mildly. We know what happens when we are under-vaccinating against measles, for example, or pertussis, for example. Certainly for things we've not seen in this country for a very long time, such as diphtheria and the rare case of tetanus. So in terms of risk versus benefit, the risk is largely theoretical, and those who are far more knowledgeable about vaccine immunobiology than I have signed off on this being a good idea. The benefit, of course, is to capture our patients when they arrive for COVID-19 vaccine and also get them for the other vaccines as well. So there you go. The short answer is there's no data yet. The longer answer is there isn't data, but from a scientific perspective, it is very likely that this is both safe and efficacious. Okay, next question, and again, on the lines of emergency use authorization, what is the process for the COVID vaccines to move from their current EUA, emergency use authorization status, to full approval? And this questioner very appropriately identifies concerns or questions about that process as a potential barrier to vaccination or a cause of vaccine hesitancy. And I also have encountered this. How do I know it's safe? I mean, they haven't even approved the vaccines yet. So what is the EUA? And as I think we all understand, it is an authorization given when a product, in this case a vaccine, is felt to be safe based on some amount of data, typically at least 2 to 3 months worth, in a setting where there is a medical or a clinical crisis that can be in some part mitigated or prevented by use of this product. So certainly that would apply to the current pandemic. The country and the world is and was desperate for vaccine intervention to reduce the caseload, reduce the mortality, reduce the severity, and vaccine products were tested, albeit put together very rapidly. That doesn't mean that the science of the vaccine discovery and the science of the phase 1, 2, and then 3 trials was inadequate. It simply means that there is a very strong political and also financial will to support this research, and things came together very quickly because the country was in and is in the state of desperate need. So based then on the available data, the safety outcomes and the efficacy appeared quite excellent. To go from emergency use authorization of any investigational drug or product or vaccine typically requires longer period of safety and outcome data. And the typical time frame that is posted by the FDA and by the AzAAP is 6 months with the following 6 months to review the data. So as I record this podcast, we are continuing to acquire data for all the vaccine products that currently have EUA licensure in the bid to then provide that to the FDA after 6 months' time, which we have, and then bid for full approval. And in fact, Pfizer has begun that process for its vaccine for ages 16 and up, its original age range for the emergency use authorization. So there you go. To those, and appropriately, those who have questions like, gosh, it's not even approved yet, we can say, no, not yet. It's only and truly only a matter of time because the ongoing efficacy or outcome data, as well as the safety studies of the vaccines, continues and remains excellent. Somewhat related then to a safety question, the questioner also goes on to ask, another objection is the issue that's been raised about the vaccines affecting future fertility due to the similarity of the protein in the vaccine to a protein in the placenta. What can I talk or what can I share about that? So it turns out the original concern about which this concern is based came from a German epidemiologist who, in a very rigorous dogmatic way, noted that there was apparent similarity between a small part a genetic code of the placenta protein called synectin-1 with the spike protein produced by the SARS coronavirus 2. And if so, if there was this genetic similarity, then perhaps one might make antibodies against both while responding to the vaccine. So this concern was addressed thoroughly, both in the laboratory setting by looking at gross comparison on the genetic code, and found that there was truly no significant similarity whatsoever, and then also rigorously clinically tested in clinical trials. And so both purposeful studies looking at any potential autoimmunity against the placenta and the protein synectin-1, as well as all of the safety studies and all the existing vaccines to date worldwide, many of these vaccines have unwittingly been provided to women who became pregnant during the vaccine trial, already were pregnant, or conceived just at the end of the vaccine trial. And there have been 0 cases noted and identified of any autoimmunity or any challenge to fertility. So this is one of those where, again, from an abundance of caution, this is speaking as a scientist and a clinician, a concern was raised, but it does appear to have been addressed very rigorously, again with an abundance of caution and transparency. And we can reassure those in our practices that not only is there no evidence of a autoimmunity to the placenta, in fact, that concern has been very specifically disproven. So great, fantastic, wonderful. All right. Let's see, what's next? What about, is there a waiting time recommended between giving COVID-19 vaccine and immunotherapy? So by this, I'm going to assume the questioner is asking, giving an immunotherapeutic drug which might compromise the vaccine response, or put the patient at risk as an immunosuppressive agent for developing disease. So the second one is easier. So the currently emergency use approved vaccines in our patient population, 12 and up, the messenger RNA vaccines are completely inert. There's no potential, no possibility that an immunocompromised patient would somehow acquire COVID-19 by getting the vaccine. And in fact, again, that's the science, but also that clinically has been tested quite rigorously, and large patient populations of people with immunodeficiencies, including cancer patients, active cancer patients, cancer survivors, those with HIV/AIDS, those on active immunosuppression, all have been evaluated post-COVID vaccine. And while their seroprotective response has not been as great as an otherwise healthy individual, there have been no cases of untoward complications or start of infection, breakthrough infection due to that vaccine strategy. To me, the slightly more concerning component would be, is there the potential to down-regulate or to suppress an adequate immune response by giving an immunomodulatory agent to a recent vaccine recipient? And as it turns out, the major share of the vaccine response occurs truly in the first 72 hours. That is when the antigen-presenting cells are digesting that provided messenger RNA, or in the case of the Janssen pharmaceutical Johnson & Johnson vaccine, the adenovirus vector presenting the code for the spike protein. But the immune recognition step of the adaptive immunity to create a vaccine response occurs rapidly within the first several hours of exposure. And then the cascade of collecting and then proliferating the CD4 T lymphocytes and the B lymphocytes to ultimately make antibody to that spike protein occurs in a huge peak in the first 72 hours, and then in a gradual fashion, sort of the second end of the bell curve, if you will, over the next week or so. So although this has not been specifically recommended, if it is possible to hold off on immunomodulatory therapy until at least 1 or 2 weeks after COVID vaccine, that would be ideal. Now, a specific subset of this question would be those individuals who, for whatever reason, have received or are about to receive intravenous immunoglobulin. For example, somebody who has hypogammaglobulinemia, somebody who is in recovery from a post-infection encephalomyelitis, who is receiving scheduled IVIG. We all know, and we certainly should remember because it's a board's question, that receipt of intravenous polyclonal immunoglobulin for any indication is going to down-regulate or suppress a normally appropriate vaccine response to routine vaccines such as the polysaccharide vaccines, the conjugate protein vaccines, and the messenger RNA vaccines for at least several months, and certainly negatively affect the live virus vaccines, MMR, varicella, etc., for up to 11 months. So if somebody has recently received intravenous immunoglobulin, they are likely to be less of a vaccine responder to a COVID-19 vaccine than the otherwise healthy individual. So keep that in the back of your minds just when you're looking at who can and should not get the vaccine. Again, this is not a safety issue. This is truly just a vaccine response issue. Speaking of safety issues, though, the next question asks, how concerned should we be about recently reported potential cardiac side effects of the COVID vaccine in teens and young adults? This is in reference to reports emerging over this past weekend and hitting the news media just on Monday, yesterday, the May 24th, of a few cases of myocarditis, as reported in the media, in teens and young adults who are recipients of the COVID-19 vaccine. I wish that I could provide a completely transparent and well-informed scientific opinion about that, but there is minimal, in fact, there's no data that has been released. However, several researchers, as part of the FDA and the Advisory Council, and also Dr. Yvonne Maldonado, coming to us out of Stanford, who do have insider knowledge, have said there is as yet no indication that those myocarditis cases were directly due to the COVID-19 vaccine. And in fact, the numbers of cases of myocarditis reported in this patient population are no higher than that expected normally in the normal course of disease screening. So it is likely that there was no specific relationship. However, as we all know, this is a very a rigorous time when anything and everything which is COVID-19 vaccine related is under intense scrutiny. It makes sense that individuals who developed a cardiac disease would come to immediate medical attention, and the question would appropriately be asked. Could it be due to vaccination? Could it be due to something else? So for right now, it would appear that the questions are being addressed by looking at those cases very rigorously, out of an abundance of caution. But as of right now, there's no indication that the vaccine itself causes any increased incidence of cardiomyopathy, myocarditis, cardiac disease, or anything like that in those patients. It is also possible, I have to note, that those individuals may themselves already have had COVID-19, which we know can affect, through a hyperimmune or a post-infectious process, myocardial tissue or pancardial tissue. And we know this for a fact from our patients who have acquired and developed multisystem inflammatory syndrome in children, MISCI. So we do know that there can be disease of the heart related to infection with SARS coronavirus 2 due to an immune response, but we do not know, and so far I would caution against any overt concerns expressed about the vaccine response doing the same thing. Right now it seems to be a situation which is being evaluated appropriately. I also should note that the same concerns were raised early in the vaccine series for adults with Guillain-Barré syndrome. And as we have experienced with other vaccines, Guillain-Barré vaccines is a lightning rod for concern and angst. However, the numbers of cases of Guillain-Barré in COVID-19 vaccine recipients, as it turns out, did not exceed the normal numbers expected in the normal course of monitoring for that disease process. And so the FDA very clearly stated that there was no discernible causative relationship between COVID-19 vaccine and Guillain-Barré. I suspect that we will hear in the near future that the same is true for these cases with myocarditis/cardiomyopathy. And then the last question I have is I've heard that the vaccine sites are not reporting an increase in traffic after the Pfizer vaccine was approved for 12 years of age and up. What is the data for our younger patient population in terms of receiving the vaccine? I've not seen hard data, only because the total numbers of vaccines administered is down across the country. I think we've done an incredibly great job of a rapid rollout of vaccines and have vaccinated the most willing people. Now the hard work really begins, or has begun, quite honestly, to address those who are vaccine hesitant and even those who, the vaccine hesitancy doesn't have to be inappropriate, by the way. I need to say that for the record. It can simply be somebody who has valid questions about the science, about the outcomes, about their personal safety. And there's certainly are valid sources of vaccine hesitancy from those populations who are disenfranchised for whatever reason. So I think that we're seeing a fair amount of that impacting the total numbers of COVID vaccinations, and that also is going to potentially affect the numbers of children 12 years of age and up who are getting vaccine. Anecdotally, of course, I've heard a fair number of colleagues, friends, people in Tucson, where I practice, who ran right out on day one of the vaccine approval to get their kids vaccinated. And the social media is filled with positive posts about that. It's kind of nice to see a counterpoint to the potential for negative posts on social media as well. So it's a great question. I don't have a good answer for you, and I suspect that data will be forthcoming, but we are still relatively recent in the approval process of the Pfizer vaccine and hopefully the near future Moderna vaccine for 12 and up, but before we can actually start to see a significant uptake in those patients. So that is, I think, the end of the questions. I'm just reviewing my list here to make sure that I covered everything. And it certainly seems that I have. So, as always, thank you for listening to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. In the meanwhile, keep those questions coming. Thank you so much for listening. Hang in there and keep doing everything you do. I greatly appreciate all that you do. Thank you so much.